Okay, so welcome. This is information technology for fundamentals. So let's get started. So your medical record, the patient's chart, is a legal document. Don't ever forget that. It's confidential, it's permanent, it's admissible in court. That's important also to remember. So nurses are legally and ethically responsible to ensure the confidentiality of the chart, right? And to make sure that the information is accurate also. Only healthcare providers who are directly involved with the patient have access to a patient's chart. You should always document what kind of care you provided specifically, and it should reflect the nursing process, which we're going to go over. That's ADPI, assessment, diagnosis, planning, implementation, and evaluation. So most medical records are electronic now. It's sometimes challenging to protect the privacy and safety of that information, but we talked about before with HIPAA, never share passwords and those types of things. So what do you document? You should document whatever you assessed objectively and subjectively, and we'll go specifically about that in a little bit. Medications that were administered, nursing actions, treatments, how the patient responded to all of that, and what education you provided. Okay, so what are the elements of documentation? It's got to be factual, so not an opinion, anything like that. So subjective and objective data. Subjective data is information that you get from the patient. Okay, I've been up all night, I couldn't sleep. If the patient tells you that in the chart, in quotation marks, patient stated, quotation, I've been up all night, I couldn't sleep, right? So subjective data is whatever the patient is telling you with regard to your assessment, right? Objective data are things that are measurable, things that you can see and feel and hear and assess. Vital signs, blood pressure, heart rate, those kinds of things, right? You want to make sure that the charting is descriptive, but just to the point. So, instead of writing client is agitated, I say all the time, what does that mean? Because agitated could mean a bunch of things, right? So instead you would write client is yelling in his room, pacing back and forth. That paints a picture for me. So when I read it, I'm like, oh, he's agitated, he's yelling. So if you just write agitated, it doesn't really tell us what's happening, so you want to be specific. Accurate and concise. You want to talk about your facts and the information that very precisely, and don't use unnecessary words. I always talk about the notes in nursing homes. Receive patient supine in bed, A&O times 3, NAD, no acute distress, VSS, vital signs stable. What does any of that mean? It doesn't mean anything. So it's a lot of words that told me nothing about the patient. So you don't want to write that type of thing. Sometimes less is more, is what I'm trying to say. You want to write just the facts, as if you're talking to the cops. Just keep it in your head like that. You don't offer additional information that's subjective or your opinion or what you think. No, just the facts, okay? And make sure that the documents are timely. There's nothing worse than nurses who say, I'm going to get to that at the end of the shift. You will not remember specifically what happened. I promise. I have an excellent memory, and even I don't do that because 1,000,001 things can happen between 3 and 11, right? So you want to make sure that you're doing it as you go. Plus, you want to get out on time. You know, spend the night there, right? And make sure that your documentation is organized so it follows a logical and concise flow. This happened, then I did this, and here's what happened with the patient. So, legal guidelines for documentation. Every entry starts with the date and the time, okay? It says legibly, but most of you are going to be dealing with electronic medical records. But if you are dealing with paper, you can use blue or black ink. That's it, okay? Never leave blank spaces in a paper chart. If you write a note and there's a lot of, pages or spaces left after your note, draw a big line through it so nobody can come behind you and alter what you've written. Okay. Whiteout is a no-no. We do not use whiteout. If you make a mistake, let's say you're in a hurry and you start to chart on Mrs. Jones and you meant to chart on Mrs. Smith. Okay, accidents happen. You strike a single line through what you wrote and you put your initials and the date, and that's it. You don't write error or anything else. Okay. Single line, initials, date. That's it. If you write the word error anywhere in a patient's chart, and heaven forbid it goes to court ever, the lawyer will look and go, you wrote error. So you're admitting you made a mistake, right? I promise you. So don't do that. Make sure everything is signed. Follow, facilities have different guidelines that vary a little bit. So make sure you follow facility guidelines. And again, no personal opinions. If you walk in and you find a patient on the floor, entered room, found patient supine on floor next to bed, not patient probably fell out of bed. We don't know that. Okay. Okay. Formats. So there's different type of formats that you're going to see. Flow charts. A flow chart can show you like vital signs over the past week. So you can trend what's been going on. Has their blood pressure been elevated? Has their blood pressure been low, or has it been kind of steady? Right? That's a flow chart. Narrative documentation is like writing a story, right? That's just like telling, when you do an initial assessment on somebody, it's usually a narrative in there. Because, you know, patient came to ER with complaints of chest pain, you know, patient was out shoveling snow prior to this happening, patient stated, blah, blah, blah. So you're telling me a story, right? Charting by exception can be dangerous. That's my own personal opinion, doesn't reflect the opinion of AHE Schools or any of its affiliates. So they use forms that just have checkboxes. So, and it goes system by system. So integumentary. And there would be a checkbox within normal limits. So if you don't find anything, there's nothing to write, right? The only problem with that is you may not remember specifics. And just a quick story, patient was in for a knee replacement. This is years ago. And she wound up bleeding out in the middle of the night. When you looked at the documentation, it appeared that the nurse went in at 7 p.m. and didn't check her again until 6 a.m. And we know that's not true, right? However, the way that charting looks, I would always write a little blip every hour or two, like, you know, patient sleeping soundly, whatever, something to show that I had been in and I checked on that patient, because charting by exception always scared me just a little bit, you know. Problem-oriented medical records. You probably won't see these, but I'll go over them just in case, right? There's SOAP, there's PI, and there's DAR. And the next slide, I'm going to explain what they mean, okay? Then electronic health records. We know that eventually everything's going to be electronic. There will be no paper. And there are advantages to electronics and technology. I love technology, right? Standardization, accuracy, legibility. Years ago, there would be 6 of us gathered around the nurse's station, staring at a chart going, what did that doctor write? Is that an A? No, he writes his A's like this. Literally, it would take sometimes 10 to 15 minutes to decipher what a doctor had written. So you see how errors could happen, right? So the beauty of tech is that you can read it. It's legible. A lot of people have challenges. Oh, I hate technology. I don't want to learn, but doing it this way all my life. I mean, you know, we have to stay relevant, right? This medicine is always changing. It's fluid. We learn new things every 10 seconds. So you want to be in this field, you have to stay relevant and you have to stay current. So you have to learn how to work the stuff, right? And listen, I did it, and I grew up with a yellow phone on the wall, like I say all the time. So you can do it, right? And the documentation rules and formats are the same pretty much with electronic versus paper. So not much of a difference. So what is a SOAP versus a PI versus a DAR? SOAP is the most common nursing note. And the S stands for subjective data, the O is objective data, the A is your assessment, and the P is the plan. And it's written just like that. What did the patient tell you? What did you observe? Vital signs, you know, blah, blah, blah. Basic assessment, and what are you going to do? What's your plan for this patient? What does this patient need? PI, you don't see that much anymore. Problem, intervention, evaluation, same thing, just shorter, right? And DAR, kind of the same thing. Data, which is the data that you've gathered, subjective and objective. Action, what'd you do? Response, how'd the patient tolerate it? Did they get better? Did they get worse? You know, whatever. So those are the 3 formats. But again, you may not ever see those formats. Okay, we'll talk about change of shift report. So, at the end of a shift, I'm sure many of you have seen this, the nurses coming on versus the nurses going off. Going off, they're going to give report to the ones coming on. What do you have to tell them? What is important? Because if you told them everything about every patient, you'd be there all night. Okay. So most of the time reporting's face to face. There are some hospitals and some facilities that do recordings. And some do walking rounds. I like walking rounds. What that means is the oncoming nurse gets with the one that's going off shift, and together she gives report as they walk down the hallway and check on each patient and gives report about that patient. So this way, not only are you giving report, but you're checking before you leave to make sure everything is copacetic and that there's not a problem with the patient. Okay. Very rarely do I see that happen anymore. In the hospital, we used to do that all the time, but so what needs to be in that transfer report? So whatever is significant objective information about the client's primary problem, like why are they here? What's their problem and what's been going on? For example, they were just ordered an antibiotic, right? Because of an infection. Just diagnosed with an infection. We just got the UA-CNS back, urine analysis, culture and sensitivity back. Patient was started on ciprofloxacin, but they got their first dose today. Like, you would want to include that. You don't need to include every med that they're on, but PRN meds, I just gave them a pain med at 10 o'clock. You would want to include that, right? That makes sense, right? Common sense. No gossip. I feel like I shouldn't have to say that, but don't tell me about the crab legs y'all had the other night and how good they were, because I don't want to hear it. And like I said, changes in meds, treatments, procedures, anything that was different, right, during your shift, so that the oncoming shift knows kind of what's going on. Telephone reports, and this is important. There's a form called an SBAR. Okay. So I did triage for a doc in Florida, cardiologist. And I would get a phone call from a nurse saying, I'm with Mrs. Jones and her heart rate's 120. Yeah. What else she got? What? I'm not there. So how about blood pressure? 120, regular or irregular? Does she have a diagnosis of AFib? Is she on an anticoagulant? And if she is she therapeutic? I mean, I have a million questions that you should be telling me. So I had this moment, like this epiphany, where I said, now I get why doctors get mad and hang up on nurses sometimes. I did, because I was like, are you kidding me? Like, okay, what else is going on? I'm not there. I can't see the patient. So you want to make sure when you're calling a doctor or a nurse practitioner or a PA, you're giving them information because you're their eyes. They're not there. So you need to make them understand, why are you calling them? Obviously, you need something, right? So an easy way to do it is to use the SBAR. This was probably one of the best inventions within the scope of healthcare, like ever. So SBAR, situation, background, assessment, request. Okay. So it makes it easy. So this way you have right in front of you what you are calling hi, doctor, blah, blah, blah. This is Mary, and I'm the nurse taking care of patient Mrs. blah, blah, blah in room, blah, blah, blah. Her primary diagnosis, blah, blah, blah. Here's what's going on right now, blah, blah, blah. She has a history of blah, 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 right? Allergic to. So you're giving all the information. And then at the end, here's what I need from you. Could you please give me an order for blah, 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 right? When you do it like that, you're more likely to get a positive response from a physician. I mean, I would hear nurses going, wait a minute, and I'd hear paper shuffling, right? Because they didn't know it. Like, you got to get your stuff together before you call the doctor, right? Or the doctors. Imagine getting like 30 or 40 of those calls a day. You'd be like, wanting to hang up on them too. I mean, So, and then after you speak to the doctor, you document telephone call to doctor, whatever the doctor's name was, blah, 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 regarding blah, 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 received order and noted, blah, 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 right? Okay. Here's an example of an SBAR, right? So it gives you situation, Dr. Jones, Sharon Smith's calling from the CCU at Mr. Holloway, room 217, 55-year-old man. He's pale and sweat. I wouldn't say that. I'd say he presents with pallor and diaphoresis is the way I would say it. But, blah, blah, blah. So you get the idea. This is the way it should be. So she's asking the doctor for an order for an EKG and labs, and she'd like the doctor to come take a look at the patient, right? And when it's done like this, everybody wins because you get a quicker answer from the doctor. So the patient gets taken care of more quickly and you get what you need quicker, right? It's a win-win for everybody. That's one form, SBAR. They have lots of different types of SBARs that are geared towards specific venues of nursing, long-term care, subacute, the hospital, blah, blah, blah. But this is your basic SBAR form for you guys to see, okay? Telephone orders. So you will get an order from a doc or an NP or something over the telephone. Always read the order back, word for word, okay? Word for word. So when the doctor says, I want you to, blah, 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 you go, okay, let me make sure I've got this straight, doctor. You just ordered furosemide, 40 milligrams, PO, stat, right back. Because if something happens and there's a mistake, it'd be easy for someone to say, I didn't say that. It's not what I said. How did you hear that? And also, people have accents sometimes phone connections are choppy or they go in and out. So you want to make sure that you're getting the order right, and if they order something that doesn't seem to make sense, you question it. That is your right. You have a license. You question it, but it's got to be, if you're questioning something, make sure you have a valid reason as to why you're questioning it, So like if the doctor said, give, 250 milligrams of digoxin, you'd be like, doctor, did you mean 250 micrograms? Because 250 milligrams, you would kill somebody. See what I mean? Stuff like that. Okay. And then you make sure that the doctor signs the order. They usually have 24 to 48 hours. Most facilities have protocols in place for that as to when they should sign it. All right. Transfer reports, like handoff reports, where patients going from one floor to another, or patients going from one facility to another. So you want to make sure that they've got the face sheet, and face sheets, whether it's electronic or paper records, all have all the patient's demographic information. So their name, their address, their date of birth, their next of kin, blah, 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 all that protected health information. If they were employed, what their insurance is, all of that's on that face sheet, okay? And then you want to make sure that you've got any recent orders in there, any specific equipment they need. How do they ambulate? Are they chair bound, bed bound? This needs to be a comprehensive report. Do they have advanced directives or a DNR? Is family involved? And if they are, who are they? Yada, yada. So this is a more comprehensive report because you want to make sure that the next facility is getting all the story, right? Okay. And then incident reports, and this is important. I mean, everything in this PowerPoint is important because these are all board questions. So again, I cherry pick. Incident reports, when something happens that's unusual to either a patient or an employee or a visitor, any of those three things, then an incident report is usually completed. Incident reports are internal documents. They do not leave the building. They don't go in the patient's chart. They don't get faxed to the doctor. Nobody gets to see the incident report except the person who wrote it, the management team, and usually it's risk management or quality assurance department. And again, every facility has a little bit of a different protocol, but everybody has a QA person and everybody has a risk manager, right? And just to clarify, a risk manager is someone who gathers data and says, wow, we had 4 falls on that unit in a month. Let me do a root cause analysis and figure out what happened and what can we do so it doesn't happen again. That's what risk managers do. And quality assurance is kind of the same thing. Do we need to do extra training? Did somebody not do something, or, what happened and what can we do so it doesn't happen again? They're the ones that get incident reports because the point of the incident report is that they can look at it and say, all right, well, what happened? How did it happen? And how do we not let it happen again? Right? If somebody fell, if there's a medication error, if somebody didn't get a medication when they were supposed to, a needle stick, please don't stick yourself with a needle. I've been doing this 30 years, 35 years. I've never had a needle stick. Never, ever in the patient's chart would you say incident report completed or anything of that nature. So I'm going to give you an example. So You have two patients with the last name Smith. One is a diabetic, one is not. You go in and for whatever reason, shame, maybe you didn't do your 3 checks, you give insulin to the non-diabetic patient. And you walk out of the room and you think to yourself, what did I just do? Uh-oh, right? So now, the first thing that you do in a situation like that, check your patient, right? So because it's insulin and she's not a diabetic, depending on what kind of insulin you gave them, their blood sugar may drop immediately or their blood sugar might drop in a couple hours. Again, depends on what type of insulin that was given. So now you got a situation going on. You're going to have to call the doctor and tell the doctor what happened. Hey, doctor, mistakenly gave Mrs. Stella Smith 10 units of regular insulin instead of Agnes Smith. And the doctor's going to yell probably. I mean, some do, some don't. But, in my experience, you did what? And then they're like, all right, well, here's what I want you to do. Blood sugar check. So the doctor's going to give you orders, right? To make sure that that patient is okay, given that she got insulin that she wasn't supposed to get. So maybe blood sugar checks, glucometer checks, right? To make sure the patient's not going to bottom out, et cetera, et cetera. Thank you, doctor. You hang up. Now, you're going to take those orders and you're going to write a note in the patient's chart. But all you're going to write in the patient's chart is telephone call to Dr. Jones, orders received and noted. Follow? Then you're going to note the orders in the med list. So whatever, or treatment. So if it was a glucometer reading, you're going to put in the treatment. Doctor probably ordered some glucose just in case the patient were to bottom out. So you're going to, transcribe those orders. Then on the incident report, you're going to write everything that occurred and then what happened with your patient. But you are going to always make sure that your patient is okay first. So if there's ever a question, an NCLEX question about, received the wrong med or the wrong treatment or whatever, always patient first, patient safety first, then all the other stuff that you're going to do, like complete the incident report, call the doctor. Some facilities want you to call the family. That's fun. They'll let them know. Guess what I did to your mom. So anyway, so just so you know, with incident reports, very, very specific, and the board likes to ask about them. Okay. And I think and they only stay in the facility, never to the doctor. You may see a question that says, send the incident report to the healthcare provider. No. In-house only. Okay. That's incident reports. This is just a little blib about electronic medical records. And we kind of covered this already, but password protected. Don't share your password. Don't leave the screen up. Log out when you walk away. And never talk about anything in an open area with regard to patients, information, right? And if you are the nurse and you're walking down the hallway and you hear 2 people, boy, did you see Mrs. Jones' legs? My God, they're blown up like 2 condoms. You're going to go over and you're going to say, hey, stop. Everybody can hear you. That's a breach of confidentiality, right? So, and then, like I talked about the other day, for providing information to others about your patient, almost every hospital uses a code, like a PIN code. So when a patient's family member or somebody calls, they're going to say, hi, I'm Mrs. Jones' son, and, my code is like 1234. Then you know that you can speak to that person. But never, ever confirm or deny anyone's presence in the facility to just anybody on the phone. I'm calling for Mrs. Smith. Is she in there? Do you have a PIN? You don't say, no, she's not here. Yeah, nothing. Do you have a PIN? No? Sorry. The end. Okay? Don't provide information to anybody. And that is the end of that one. That was pretty easy, right? So let me stop the share and let me stop the recording and